Howard, do you want to go ahead and do introductions and get us started?
Sure. So welcome everyone to 3D Echo, the perinatal mental health. I'm Dr. Ariela Frieder. I'm a perinatal psychiatrist. I work at Frontier Psychiatry. By now I feel everybody knows me. So why don't we introduce ourselves? Like, we are not so many, so we can go around and introduce ourselves. So Megan, do you want to start?
Sure. Hi there, my name is Megan Fallon. I'm a mental health therapist in Billings. I'm an LCSW and a perinatal mental health specialist. I primarily work with adolescents and moms. I do a lot of EMDR therapy as well. And so I've recently started kind of bringing those two together, which has been really fun.
Thank you. Bree?
Hi, everybody. I'm Bree McLaurin, and I work for Healthy Mothers, Healthy Babies. And we do a lot with community supports for moms. I'm a RN by training and a mom of 3, survivor. So looking forward to another great echo.
Thank you. So I'll say how I have you here. Amber, do you want to introduce yourself?
Sure. Amber Rogers with Mountain Pacific Quality Health, and I'm also a nurse and a mother of 2 if we're going to do our credentials.
Thank you. Mary?
I'm Mary Argonis from the Mountain Pacific Hawaii office. And yes, I'm a mother of 2 boys.
Wow. So, hi, Eric. Here. What about, let's see, Casey?
Hi, I'm Caitlin Adamo. I have a private practice doing telehealth, and I'm working with moms. I also work with teens too, and mom of 2 boys as well, and survivor as well, and LCPC, and just excited to be here.
Thank you. What about you, Casey?
Hi, I'm Cassie. I'm a nurse practitioner grad student, nurse for 16 years, and mom of 2.
Sarah Beth?
Hi, everyone. My name is Sarah Beth Upson. I'm the Perinatal Behavioral Health Initiative Program Officer with the Montana Medicaid Office, and I help oversee the PRISM for Moms program and Meadowlark Initiative that's HRSA funded.
Thank you. What about you, Betty?
Good morning. I am a licensed marriage and family therapist in California, just an hour and a half north of San Francisco. Nice to be here. This is really good information. Thank you.
Thank you for being here. Hi, Gavin. Can you introduce yourself?
Hi there, I'm Gavin Wisdom. I'm with Partnership for Children. I am the coordinator of Project Welcome here, which is a perinatal wellness program.
Thank you. And Eric, do you want to introduce yourself?
Hi, everybody. Eric Arzubi, child psychiatrist, adult psychiatrist, and partner of Dr. Frieders at Frontier Psychiatry.
Thank you. And I wonder if anyone that is not showing their cameras are off, if they want to introduce themselves. Okay. So thank you for being here. I'm going to share my screen. So today we are going to be talking about obsessive compulsive disorder in the perinatal period. So let me put this smaller. Okay. So let's start from the beginning. So let me see. So anybody, before we start, anyone wants to make any announcements? Anything to say? Okay. So before we start, I want to tell everyone about the Prison for Moms line. It's a statewide consult line in Montana that is free for providers that treat perinatal women. And we are here to support you. So if you have any patients that you see and that you need help with their mental health, you can call us. We are answering the line 24/7. There is somebody answering the line, and they take your information and they send the information to a reproductive psychiatrist who will be answering your phone call within 24 hours. So we try to help in this particular area that is not everybody has expertise, and we help with medication management and with resources. So please call if you need. So I wanted to start by talking about what is OCD, or obsessive compulsive disorder. So first, I'm sure everybody knows, but obsessions are recurrent or persistent thoughts or urges, impulses, images that come to your mind and that are unwanted, intrusive. I always explain that to patients. We'll talk more about why it's important to know that they are intrusive, unwanted, ego dystonic, and they cause a lot of anxiety and distress. And the individual tries to ignore or suppress them by doing something, or with thoughts or images, or by a behavior. So to have OCD, you have to have either obsessions, compulsions, or both. And compulsions are repetitive behaviors, or they can be a behavior or a mental act. So it can be either washing hands, ordering, checking the door if it's locked, checking the stove. And it can also be mental acts like repeating words or counting or praying. And the person feels needs to do it in response to the obsession, or because they feel they really need to do it because of a rule they have. And with that behavior or that mental act, they reduce their anxiety or distress that they were having. So, and what is very important is that it's time consuming, and we'll talk more about why it's important and that they cause clinically significant distress or impairment in social, occupational, or other important areas of functioning in interpersonal relationships, school, work, in any different way. But it's very important that they cause impairment. And I'll talk why I mentioned that. And also, it's not because of the effect of a substance or another medical condition, and it's not because of another mental disorder. So OCD, obsessive compulsive disorder, in the general population, we see it has a prevalence of 2 to 3% worldwide. So I'm going to focus in pregnancy and postpartum. So what is very interesting is that, and initially it wasn't really known what was happening, and it's still kind of not known very much what happens with OCD in pregnancy and postpartum. But people started hearing, professionals started hearing that women started saying that they were having OCD related to either pregnancy or postpartum or some reproductive event in their life. So they started doing studies, and here I show you like a small case control study where they found that women that had children, they said that pregnancy was associated with OCD onset more often than any other life event in their life. So 39% of the patients, and 30% had no specific life event associated to the onset of OCD. So it's really interesting that pregnancy was they could think that pregnancy was associated with their OCD. And also it's interesting that of the participants in the sample who indicated having had abortions, 75% indicated that OCD was associated, the onset of OCD was associated with these abortions. And this has been corroborated in other studies. So this is very interesting and made people think that there might be a big association, and there are more studies in this particular subject. So it seems that there might be an increased vulnerability to OCD during the postpartum period. So, but perinatal OCD is usually undiagnosed and undertreated, and as I was saying, it's largely understudied. And what is important about it is that obviously the woman suffers, but it's not just her. You know, this really affects everyone in the family. And it has an impact in the woman, in the marriage, in the financial situation, and we'll talk about that because what I see a lot and what is written in the literature is that women feel so scared of their obsessions, of being alone with their baby, because they have thoughts of hurting their baby, that many times they ask their partner to stay with them. So I've had a lot of patients that they are asking their partners not to go to work, to stay with them because they are scared of acting on their obsessions. So it's not that they are going to act, but they are scared of them. So it's really have an impact and a burden on the whole family. And you can imagine OCD per se can have an impact, but when you bring a baby into the picture, it makes things much more difficult. And one of the things we see in perinatal OCD is a lot of avoidance of the situations related to the obsessional fears. And I don't know if I told you, but like I had a patient that she had obsessions about her harming the baby with knives. So she was telling me that she was alone one day with the baby and she was hungry. So in order to eat her chicken, she was cutting the chicken with 2 forks. And like a lot of patients telling me that they asked to remove the knives from the house, or a lot of them avoiding the baby or avoiding being alone with the baby because of their fears. So it's really important to pay attention to this. And a common theme in these obsessions is that they are uncertain if they are going to harm or if they made a mistake. So it's not just a harm that they are going to do something, but what if they did something that was wrong? And also the harm can be, oh, what if I hurt my baby, like with a knife, or like I have a patient that she tells me, what if I crack my baby's neck with my hand? But sometimes they think, what if I do it without even noticing that I'm doing something? So there is a lot of what ifs and fears. So the cause of OCD in pregnancy, we don't really know very well how it goes. Some studies suggest that it's stable during pregnancy, but gets worse in the postpartum. And some studies suggest that actually pregnancy may precipitate a worsening of symptoms. But what we see is that there is two different things that happen. In pregnancy, it's more associated with contamination obsessions and washing and cleaning rituals. In contrast to that, in the postpartum, it's more about obsessions about harming the infant and avoidance of the cues, that the fear cues, whatever makes them fearful that they will act on these obsessions. So this is why I wanted to mention that it really has to impair their functioning, because obsessions are common in the general postpartum population. So they did studies and they saw that 1 in every 15 childbearing females had unwanted thoughts to harm their newborn. And these thoughts can happen independently of being stressed or having any stress-related variables. And they usually experience them as passing, so they are not persistent. They don't stay there for a long time. But the most commonly repetitive thoughts are about sudden infant death syndrome. And there is a compulsive check-in to check on the baby if the baby is breathing. So this is seen in the community. So it's important to know that not because of having this like a spasm, it means you have OCD. This is kind of happens in the general population. So it's very important to know that usually OCD is associated with depression. And usually what I see and what is written in the literature is that the OCD starts and then a few weeks later, the depression starts. And it happens a lot because it's very distressing to have these thoughts, you know, and so women get depressed. We will also talk later on about the fact that there are obsessions in depression, in postpartum depression, that can happen. But this is different. These are women with perinatal OCD that start being depressed after because of the OCD. The start of the postpartum OCD is abrupt. It starts very abruptly, usually in the first few weeks postpartum. As I said, the obsessions are about harming the child or killing the child, and very aggressive. So images of the baby head cracked and bleeding, thoughts of throwing the baby down a flight of stairs, and fear of mistakenly putting the infant in the microwave. I told you about my patient that was thinking about grilling her child. So they are very aggressive thoughts and very scary. And the content can include child sexual abuse, which can be very distressing for the mother. So check-in rituals are very prevalent for compulsive symptoms, but also a lot of avoidance, and we'll talk more about that. What was very interesting when they were doing all these studies, they saw that actually some fathers had postpartum obsessions. And initially, so when they did the sample of the community sample, and they saw that obsessions are common among women in general and without meeting criteria for OCD, they also saw that that happens in males with children. But in this particular case report, they saw that 4 fathers had postpartum obsessions. And these 4 fathers had unwanted thoughts about being responsible for harming the newborn or the unborn child. And usually the men were less distressed by these thoughts compared to the women. But it's interesting that it also can happen in fathers. So I wanted to differentiate between postpartum OCD, postpartum psychosis, and postpartum depression, because all of them can have thoughts that can be aggressive and can be scary, not always for the patient, but for whoever is listening to them. So in postpartum OCD, we said that the obsessions are ego dystonic. The patient doesn't agree with the thought. It's intrusive and unwanted, and it triggers a lot of fear in the patient and anxiety. They usually are not psychotic, and as I said, they get very distressed by their thoughts. In postpartum psychosis, the thoughts, actually, they agree with the thought. They are not, they can be distressed by the thought because it can be distressing thinking about certain things, but these are delusions mostly, you know, they are not really disagreeing with what they are thinking. And even if they have obsessions, the obsessions are not so prominent, and the thoughts of harming the baby are more delusional. So they can have delusions, they can have hallucinations, and usually they are not so distressed by their thoughts. And in postpartum depression, they can have all the negative, all the depressive symptoms. They can have their negative thoughts about themselves, about life, and but they can have obsessions. So they can have the thoughts about harming, unwanted thoughts about harming the baby, about something bad happening to the baby or to themselves. that can be seen in postpartum depression. It's one of the features of postpartum depression. If they have psychotic symptoms, usually it's congruent with their mood. But they are distressed by these thoughts, by these obsessions. So this is very important to know the difference, because if somebody comes and says, I'm thinking about harming my baby, you really want to do a very detailed evaluation to know if the patient is really thinking about it in a way that will act on it, or is it an obsession that the patient is not going to act on it and is actually very scared of their own thoughts. So this is very important, not just for the patient to know, but also for the providers, that the obsessions in the postpartum, no matter how aggressive or horrific, are not associated with an increased risk of committing harm. That's really, really important, because women will be scared of acting on their thoughts, but they will take long steps not to act on them. As I said, some will ask their family member to stay with them. Some of them will avoid their baby or avoid certain situations, but they will really take long steps not to act on their thoughts. And because their thoughts are really experienced and senseless and unwanted, and they don't go with what they really think or who they are, you know? And as I said, they engage in a lot of avoidance and rituals in order to control these thoughts and not to commit the terrible act they are thinking about. And they have a lot of anxiety. This creates a lot of anxiety. So it's very important to screen for OCD, not just for OCD, but to ask for obsessions. Because what I find is that women, even with postpartum depression, when you ask about the obsessions and they have them, they feel so much better after they can talk about it and you normalize it. So I usually say, you know, you have the postpartum depression, having thoughts, unwanted intrusive thoughts of harming your child or harming yourself or harming somebody else. It's very common. Have you been experiencing that? And that really make them feel like you take a weight off their shoulders. So it's very important to ask, but it's very important to screen for OCD early in the postpartum, because it can start early in the postpartum. So you can start by asking a question, you know, is it not uncommon for new mothers to experience intrusive and unwanted thoughts that they might harm their baby? Have any such thoughts occur to you? And you can also ask about compulsions, you know, any excessive washing, checking behaviors, and any rituals. But if they answer yes to this, you need to follow it with a more detailed evaluation. So then you can use the Y-box, that is an easy to administer self-report scale, and that will help you to evaluate the severity of the symptoms and also to monitor the response to treatment. But really doing a detailed evaluation and really talking to the woman and asking a lot of questions about their obsessions and how it's affecting them and how it's interfering with their life and the life of others around them, it's very important. So in terms of treatment of OCD in the perinatal period, we don't have much information in terms of like research done about the treatment of OCD in the perinatal period. We use the treatment that we have according to standards that is used in the non-perinatal population. So we usually do an adequate trial of medication, 10 to 12 weeks. And usually the medications that are of choice are the SSRIs or clomipramine, and you have to use it with good doses and to see if you have a good response. In terms of pregnancy, the SSRIs, and we spoke about them, SSRIs are the medications like sertraline, paroxetine, escitalopram, citalopram, I'm thinking if I'm forgetting, and fluoxetine. And those are the first choice in pregnancy. So they are not associated with malformations. There was some concern that they were associated with malformations. New studies and well-done studies suggest that they are actually not associated with malformations above the risk in the general population. They are also well tolerated through pregnancy. They might have a small risk of baby being born a little bit before time, but that's not more than 1 week before time, or being a little bit smaller for their age. Babies, when they are born, they can have what we call the adaptation syndrome. This is what we see the most. It's like 15% of the babies can have some symptoms that don't last more than a week. And the baby can be colicky, fussy, breathing a little fast, not sleeping well, not feeding well, but that goes away. That is also seen with anxiety and depression. So it's very hard to tell what it is. There are some studies that suggest that that's actually related to a genetic predisposition in the baby. We don't really know yet. The reality is that was seen more with Paxil, paroxetine, and fluoxetine. And because at some point, some studies suggested that paroxetine was associated with heart defects, and the FDA changed the classification of paroxetine from C to D. A lot of people don't use paroxetine in pregnancy, even though more later studies and meta-analysis suggest that that might not be the case. But still, like if you have to choose, you are not going to choose paroxetine as your first choice. But it seems that paroxetine and fluoxetine are the one more associated with adaptation syndrome. The other thing that can happen, so in terms of, there are no risk of miscarriages associated with these medications. There is some early data that suggested risk of pulmonary hypertension of the newborn, but newer data doesn't agree with that so much. So that's still in study, but it seems that better than studies don't agree with that information. And then the studies that were done and followed children until they were 6, 7, 8 years old don't see any risk associated to taking SSRIs for the mother during pregnancy. So that's very reassuring. In terms of clomipramine is an older antidepressant. It hasn't been used much in pregnancy. That family of medications seems to be safe in pregnancy. However, it hasn't been used much. And there are some studies that suggest that it might have a risk of malformations. However, the majority of the studies don't see that. I really don't use it much because of the side effects. And we usually now try to treat OCD with the SSRIs. The other one that we use for OCD that is an SSRI is fluvoxamine, Luvox, and that's also, we use it in pregnancy. So you should use the medication for at least a year in the postpartum OCD after you got the therapeutic response. I usually tell the woman, since you started feeling well, we'll wait a year of you in this dose. And after a year, if this was your first time of having an OCD episode, we might try to taper off and see how you do without it, but at least for a year. In terms of cognitive behavioral therapy, I was reading about it, and again, there is not much studies done in pregnancy about it. And what it's more effective is ERP, exposure and response prevention for OCD. And there is some controversy of what to do in pregnancy, because you don't want the woman to become, to increase her heart rate so much, have physiological changes so much in pregnancy. And when you are exposing them to their fear, to the cue that is causing the fear, it might be that's the situation. So some studies, there is very little information about it, but some people feel you need to wait after pregnancy, but some people suggest that actually you can use it by monitoring the heart rate. And also because it seems that women that are pregnant, when they are pregnant, they don't respond to the stress with so much physiological changes as other women that are not pregnant. So this is an area that is still being studied. So let's see, any questions about this?
Is it associated with like insomnia as well? Like, is that an exacerbating factor, like some of the others?
You mean like if OCD is exacerbated by insomnia in pregnancy or postpartum?
Yes.
So that's a very interesting question. I didn't read anything that insomnia was a trigger of OCD, but I can see it happening, you know, in somebody that is not sleeping, it's getting more stressed, you know, but I wonder also, because what I see also is that women with OCD might not sleep because they might stay up checking on their baby. So I wonder what starts first, you know? So any questions, any thoughts, comments?
I have a question. Like, I'm kind of wondering, like, what if like the obsessions are a lot more, or I guess the compulsions are more like cleaning related or something like that, and a little less on the like worried about the baby being harmed or threatened, you know?
Yeah.
And when it's like, it's definitely, you know, like taking time out of your day, but maybe not like an hour, you know what I mean? It definitely is having significant impact on your life. And it's distressing. And I'm just wondering, like, what if it's like a step down a little bit? Like, do you tend to see that as a little bit more anxiety, or, you know what?
So
I'm wondering.
you mean, no, so you mean like it's not so distressing. It's not causing so much of impairment in the woman's life, the symptom.
Yeah.
So, you know, first of all, it depends. I think that's what really depends, you know, how much it affects their functioning, you know, how much it's distressing for the woman.
Mm-hmm.
And if the woman has a history of OCD or not, you know, because if a woman comes to me and tells me, I have been cleaning more, I can't stop cleaning, but it doesn't affect me so much, but I have OCD from before and I see it coming, you know, so I might say, okay, we are on the way of getting it worse, you know, so it might make sense to start a treatment. Mm-hmm. If a woman just is cleaning more the house, but hasn't been affected by it, you know, and you can observe it and follow her and see how she's doing, you know. Like, it really depends, and if it gives her other symptoms, you know, also how it is how is it affecting her really? Because you know what, when you started talking, what it made me think is the women, and it blocked my mind how it's called, but when women are about to give birth, that they have this intense nesting syndrome, like they have to start like cleaning and arranging the nursery and like, and if somebody comes in that time, like that doesn't sound obsessive, you know, it sounds appropriate, you know, like it's part of the process, you know. So if somebody just comes one time and you don't know them, and it might be a good idea just to follow them, tell them to come back next week and see how they are doing.
Yeah.
Anyone else? Megan, I was wondering if you
Hang on,
have
I think
sorry.
I think Darcy
Oh,
has a
Darcy,
question.
Darcy, do you have a question?
Yeah, I'll try not to be long-winded on this one, but so an individual who I've worked with in the past has, with a history of OCD prior to pregnancy and childbirth, been working with them for quite a while, and they discontinued all of their SSRIs. This individual also has a history of narcolepsy, and so was taking quite a combination of pharmaceutical, wow, I cannot talk, pharmaceuticals, including some stimulants. And so they didn't want to resume their SSRI medications following birth because of pretty valid concern that without the stimulants, they would be just so exhausted without, the support for their narcolepsy, which I'm pretty unfamiliar with, quite frankly. Anyway, so they've been struggling though for, almost 2.5 years, also breastfeeding. And so really not wanting to get back on the stimulants. And so, yeah, I'm just curious if you have any thoughts on that with my rambling description of what's happening.
So do you want to talk more about the case and maybe we can discuss it more, so it sounds that this patient was on medication before pregnancy?
Yes.
An SSRI and a stimulant for the narcolepsy?
Yes.
And then they stop everything for the pregnancy?
Yes.
And when after the postpartum, they didn't want to resume the SSRI?
Because they're breastfeeding and they're worried that if they resume the SSRI, they'll feel too exhausted without the stimulant.
How are they doing?
Not great. Very severe anxiety and depressive symptoms, which have been persistent for at least the last 2 years. And I, have encouraged multiple conversations with their psychiatrist. They are working on weaning right now, which is, I think going to be really a big step forward in treatment, but continuing to come into roadblocks there. And so I guess, I see improvement and I see them moving towards a place where I think that with some pharmaceutical support, they'll start feeling better again. But it's just been such a prolonged process that I'm fairly concerned.
Yeah. And I think you are mentioning something that I didn't mention. I mentioned in the past, but I think it's important to review now, is that these medications, the antidepressants, the SSRIs that we use for these kind of situations, what happens during breastfeeding, and most of them, so the ones that have least amount in breast milk are sertraline and paroxetine, so it's Zoloft and Paxil, but all of them seems to be in low levels and very well tolerated. There are a few case reports that suggest that fluoxetine or Prozac, babies are a little bit colicky with it when the mother takes it, So, but usually they're very well tolerated by the baby, and they don't see any negative effects.
Mm-hmm.
Saying that, there is no real much data about long-term, what happens in the long term with babies exposed to these medications during breastfeeding. But if you think about a baby being exposed during pregnancy and then in the breastfeeding is much less, but still, if you have to put everything in a balance and see what's more risky. And I wonder your particular individual, how is she functioning? How is it for the baby? How is the connection? How is the bonding?
Yeah, bonding is actually going quite well, despite the fact that she has such prolonged depressive symptoms. And she really is distressed by the fact that she's felt depressed and anxious for so long, but also not to the point where she's ready to just try the SSRI medication without the stimulant. Because I think there's just such fear that, probably from a place of, she's already feeling so depressed, which, is creating a lot of fatigue and, on top of that, isolation and, just a lot of complexities in this case. But yeah, I mean, bonding is going fairly well, actually, which, and dad's very engaged, which I think is a protective factor for baby as well. But yeah, those are the things I think about all the time too. Like, as this goes on and on, what kind of long-term implications does her depression and anxiety have for the baby?
Yeah. How old is the child?
Let's see, I think she will be I think she's going to be 3 this fall.
Yeah, and that's a great question, actually, because I was going to ask the same, in the sense that I'm more concerned when a baby is a newborn, and if the baby is sick, or if the baby is preterm and can't metabolize the medications. But at this point, I'm not even concerned about the stimulants so much. And I know the stimulants that they use for narcolepsy are different than we use for ADHD, but in terms of that, I have patients on stimulants and breastfeeding for ADHD if it's really needed, It's a risk-benefit situation. You have to put it in a balance and see what is more risky. If the woman is so sedated that she can get into an accident, maybe she needs to start back her stimulants,
Yeah, well, that's a great point. And also the other thing that just came up for me as you were talking about that is she's at a point in her weaning where I think she's only down to breastfeeding once a day at this point. Like, she's so close, and it's like, maybe it makes sense to move in that direction.
Yeah. And you can tell her also, or tell the psychiatrist. You can tell the psychiatrist to call us.
Yes, I will.
For, like, we can help if the mother is still breastfeeding. But one thing is that, it sounds that she breastfeeds once a day, so she can really take the medication I don't know when she breastfeeds, but she can take the medication very far away from the time she breastfeeds. That's also a good idea. So it's not at its peak, when she's breastfeeding. If she's concerned, about that. Like, it's not a concern.
Sorry.
Yeah.
I'm wondering if you could speak to what stimulants you've seen used during breastfeeding.
So I've seen mostly dextroamphetamine, amphetamine, like what we call Adderall. That's what I use the most,
I think that's what she's on.
And usually what I say, if it's a baby, a small baby, and the mother really needs it and wants to breastfeed, I usually tell them to use the instant release instead of the extended release. So it gets out of the body faster, and use it when you really need it, like with a stimulant, you have that choice that you don't have to use it all the time to have an effect. You don't have to use it every day, If you have to work or do something now, you can use it, or drive, you can use it now, and then maybe tomorrow not use it, or maybe later on today not use it, so.
Okay, that's helpful. Thank you so much.
Sure. Thank you for bringing up that case.
Yeah.
Any other cases? Anything? Any questions?
So I have a case, actually. It's not OCD related, but I talked with Dr. Arzubi briefly this morning, so I wanted to bring it to you. So I have a mama I'm working with. I think I've mentioned her before. She had a stillbirth at 37 weeks. She's about 10 weeks out. And she's just having such a hard time sleeping. And so her midwife had prescribed some Ambien, and the Ambien seemed to be working well. It's like she has to hit it at a certain window though. Like, if she doesn't fall asleep within a certain amount of time, she's up all night. Like, there are multiple nights a week she's sleeping 1 or 2 hours, and she's just getting some really intense full body flashbacks. And like prior to going to bed. So I had encouraged her to meet with her provider. She has a ton of, it's almost like turned into this medical phobia of going back to the doctor's office and seeing her providers again. And so she was able to connect with the provider via telehealth, and it was a disaster. The provider was super inappropriate, told her that stress is a baby killer. And so like this woman was already experiencing a ton of guilt related to her job and the stillbirth, and feeling like she was at fault because she was so stressed out with her job. And then this provider just reinforced her. So she needs to get in with the provider ASAP. And we were wondering, Dr. Frieder, if you had any availability. Or we thought Melinda, we thought Melinda too, but we thought we'd check with you first.
Okay, we can talk about that, but let me tell about the Ambien. You know, I was thinking about the insomnia and the Ambien. You know, I don't really like Ambien much in general, you know, but at least in pregnancy, you know, we don't know as much about it, you know. I prefer to use like either benzodiazepines that we know more, that have been around and we have more information about them, or either like a medication like doxylamine that is antihistaminic, you know. And
doxylamine?
Yeah, so it's all, there are two ways that they sell it. They sell it as one that is a brand that is more expensive, that is called Diclegis, that they use it for nausea and vomiting in pregnancy, that is associated with B6. But there are some Unisom that also come with doxylamine. So when you buy Unisom, you have to look, is it Benadryl, or is it diphenhydramine, or is it doxylamine? The doxylamine is really helpful for sleep, and it seems to be very well tolerated in pregnancy.
Okay.
For the baby.
Right, and so she's not pregnant right now.
Oh, she's not pregnant.
She's postpartum. Yeah, she had a stillbirth in May.
Oh, I'm sorry, I didn't.
Yeah, but part of her concern is with any medications is that she wants to get pregnant again, and they're trying to get pregnant again pretty quick. And so that's part of her concern with the Ambien too, is if she can be on the Ambien if she gets pregnant again.
There are, you know, there is, I'm a little bit, I don't like to give the Ambien because of that, because and the information I read is not so great about Ambien, you know, for pregnancy. So I prefer, even if you have to give like clonazepam, you know, or lorazepam, that's even better, you know, than giving Ambien. So, yeah. I'm sorry, I didn't understand about the stillbirth. That's a really sad case, you know?
Oh, it's terrible. And that's part of the reason she's having such a hard time sleeping, is she's just getting these horrible flashbacks as soon as she lays down at night. She's like whole body back in the experience, and she just can't shut her brain off. So would like the clonazepam? So with some of those like intrusive racing thoughts, would the clonazepam or lorazepam be effective for that as well, or would there be a better option?
So no, for that will be better option with an SSRI, really.
Yeah.
You know.
And she is so hesitant about an SSRI. She has a history of depression, and she feels like, I'm really not depressed. Like I don't feel like I'm depressed like I have been in the past. I'm grieving, and I'm, you know, having a hard time sleeping. And so she's been so resistant against an SSRI. But you know, you had mentioned too.
You know, if you can get her to sleep, that will be so amazing. You know, like I think that's the first step, because some of her symptoms might get better when she's sleeping.
Right. Yeah, I agree. Okay.
So, yeah. And I understand her difficulty going back to see her doctors, you know, like, that's really, like, I had a patient with a stillborn, and she had such a hard time. She had to deliver her following baby in a different hospital, you know, with different doctors. Like, it was so triggering.
Yep, and that's what we started to explore, and it's just been like one trauma after the next. The first time she went back to the medical provider's office after the birth of her child, the nurse didn't connect the dots that there had been a stillbirth, even though it was right there in the chart, and they had her the first appointment of the day, and the first thing the nurse says to her is, "How is the baby doing?" And so it's just been like one horrible medical trauma after another, and like trauma with various providers and lack of trust with a lot of providers.
Yeah.
And it sounds like she was linked in with the best providers in town already, and so we've tried to explore alternate options. And
yeah, Megan, and this is the one that we were talking about last time. Okay.
Yeah, so basically everyone you said, Caitlin, she's had contact with them and has worked with them.
And then did you, I mean, like, I don't know the follow up after a trauma like that, but like, did she open to like a different kind of provider, like a nurse midwife or someone?
So she had the stillbirth with a midwife, and so she's very much against midwifery now and wants a medical doctor. Yeah.
Okay. So, and she was already. So then she was at. Okay.
So then she went to the medical facilities and was connected with the doctors because she gave birth, and so she's.
But what and then did you end up exploring the other hospital then that's not connected?
We did, yeah, and again, it's kind of the best. She had the best doctors already, and so she's hesitant to go to the other facility because she feels like she had the best doctors, and that's just going to be getting her back in the door.
The doctors at the other facility too. You know what I mean? I wonder if you can kind of tease out some of that inflexible thinking to some degree because I think there could be something to that, of like just kind of reestablishing something fresh and trying to create some beginner's mind or, with this and knowing that like, well, do we really know if this is the best provider or not? And how do we know until we kind of explore? And what we do know is that relationship matters the most. And so what if we give this a shot and see, how you feel with this person?
Absolutely. Yeah,
because
that's
it's not
a great
worth
point.
getting re-traumatized.
Exactly.
The other
good
thought,
point. Thanks, Caitlin.
The other thought I had, and I don't know if there is in Montana, where I used to work, they had a grief group for perinatal, for women with pregnancy losses. And it was so helpful because it was like a time limited group, like I think 6 weeks, but they ended up with like a ceremony that they did for the babies that they lost. And so it was so helpful. And I wonder, Bree, if there are any groups of perinatal grief groups in
So I've tried to hook her in with some of the ones through PSI. She hasn't been really into that. But this last week, she did say she was maybe more open to talking with other moms who have experienced this as well. So that could be an option to explore again.
Yeah.
There's a really great doula in town that Darcy and I both know, named Cerise Allen. And she does these great educations courses at St. Pat's. And while she's not in that department, Cerise knows so much about how to support women in grief and loss. I'll reach out to her and then send you an email and see if she knows of a group going on that I'm not aware of that's specific to that, or at least even connecting with another mom or someone.
Yeah. Okay. All right. Yeah, that'd be great. Thank you. And then Darcy just said in the chat too that there was a Whitefish was maybe doing that. So I can look into that. Thanks everyone. I appreciate it.
That's really sad.
Yeah, it's been really hard.
And the next pregnancy is going to be really hard,
Yes, a lot of anxiety around that already.
Yeah, and more when you get to the time of the loss,
I can imagine, yeah.
Yeah. So any other questions? Anything? I was going to ask you, Megan, actually about if you have experience with OCD in terms of like.
Not specific to perinatal, but definitely, well, I guess a little bit of my own perinatal OCD experience, but not necessarily working with clients, but definitely with just like kind of run of the mill OCD. I've seen a lot of like, I don't know, and maybe it just kind of goes in waves, but I've seen like a lot of counting, and checking. And I don't know, for me, it always seems like it's kind of, I guess like you were talking about, like the behavior is just a way to reduce that anxiety. And so a lot of the times I don't even necessarily target the behavior, first of all. We really work on the thoughts and what the anxiety is and what's driving that anxiety, and I do like a lot of kind of meditative and mindfulness work with it, a lot of kind of grounding exercises. But I guess one of the thoughts I was having while you were talking about some of the OCD stuff and assessing for it, have you seen that moms are hesitant to bring it out because they're worried about the judgment, worried about the fear?
Sure.
For example,
yes.
I met with a woman recently, and I was kind of doing an assessment, asking some of those questions, and she immediately was like, no, I don't have any of those thoughts ever. And she was really defensive and really guarded. And I think there's something there probably, but I think there's a lot of guilt and shame and probably judgment towards herself for having these thoughts and fear of what's going to happen if I say these thoughts out loud. And are they going to take my baby away? Am I going to get in trouble?
Yeah, totally. And also like for women that didn't have OCD before, it's very scary because like some of them, they tell me like, I'm going crazy. Like, you know, like they think they are losing their mind. Like, when is it real? When it becomes a psychosis, you know, that's their fear, you know? So
absolutely,
it's really, really scary.
And so I can imagine in those situations, like you were saying in your presentation, trying to normalize it. Like this is quite common. Just because you're having these thoughts, that doesn't mean that you're going to act on these thoughts. A lot of moms have these. Dr. Razubi, I think, had given a statement maybe a couple sessions ago about just like reassuring the mama that, hey, you're not going to act on this. Like, we know you're not going to hurt your baby. We know you're not going to do this. Yeah. And I can imagine that's helpful in just reducing some of that fear.
Yeah. Cassie, can you talk about what you wrote in the chat?
Yeah, I had a patient that came in, and she's at high risk for psychosis due to her bipolar and such. And she was worried about becoming psychotic. And so I was telling her some of the things, and she goes, well, we can never talk about any thoughts because in my family, if we say it out loud, my mother keeps telling me it's more likely to happen. And so it's kind of this idea that the intrusive thoughts are just that, right? They pop in, and like you were saying, it's not associated with increased harm. But for her, acknowledging those intrusive thoughts made it, in her beliefs, more likely to come true. So it was easier to internalize it, but perhaps not easier to internalize it.
Yeah. That's really difficult at the same time because they kind of keep it inside and really bothers up. It's a lot.
I can imagine it would perpetuate it. Sometimes actually saying it out loud kind of grounds you, like acknowledging it and then putting it away. Like it just unpacks that.
Yeah.
Yeah. So she's we're keeping a close eye on her.
Yeah. Yeah. I just talked to a patient today that has OCD, and she was telling me she has to tell her thoughts, she has to tell her husband what her obsessions, because it's like she feels once she tells the obsessions, it's like it will go away, it will diminish, So yeah, it's interesting how cultures work with that, how.
Well, I was sorry, just quick comment made me think of child therapy in my view, part of, or a big reason child therapy can be really helpful is because you're giving the child a language, like it's almost like language tutoring. You're giving them language to use to be able to express this, right? And if you can't express it, it turns into behaviors. And so it's like that. You're almost coaching them on how to use vocabulary appropriately and identify and linking the meat, so it's really almost like teaching them to talk about, especially if it's in their culture, it wasn't done before. I mean, same thing with kids. Yeah. So anyway, just interesting, that parallel.
Thank you. Okay, so it's 3 p.m. So thank you, everyone. It was really nice to see you. And if you want to submit a case for next time, you can send us your case, So if you want to write it up, and it will be great. We can discuss it next time. But really nice to see you all. Thank you.
Thank
Bye,
you.
thank you.
Bye.